Okay, so to continue on the topic of population health, as promised, next one up is smoking. So when we think of how smoking impacts health, there are not casual, causal impacts. We certainly know that it has impacts on stroke, it has impacts on heart disease, it has impacts on pulmonary disease, chronic obstructive pulmonary disease. It's also been linked to several cancers: lungs, larynx, esophagus, mouth, bladder. So in the 2004 Surgeon General report, it's actually been highlighted that via bloodstream it can affect all organs. Then we think of, being linked to or kind of contributes to development of other cancers and may have actually other serious health consequences. So linked to other cancers, but it's also been associated with higher likelihood of miscarriages during pregnancy and also premature delivery. So premature delivery and also low birth weight. So when we think of, costs of smoking, so costs of smoking, really it's nearing, $200 billion annually. That is indirect and also, So this is linked to both direct costs, it's a little less than a half, and then productivity losses as well. Over 5% of total health expenditures in the US are linked to sort of directly, and close to 50% of it is paid by Medicaid, Medicare, hence the taxpayers. So again, about 5% of U.S. health expenditures. So when we're thinking about how smoking impacts us, we do see that with education, we do see a lower prevalence of smoking. But the biggest thing that comes to mind when we're thinking about smoking is clearly negative externalities. In the presence of negative externalities, we know that usually there's going to be a potential role for government intervention. And here that would be government-imposed taxes to correct for the negative externalities. Now, the externalities that we're thinking about is clearly secondhand smoke, that you are affecting others around you, right? We have kids that can develop asthma, pneumonias, higher risk of SIDS among infants. During pregnancy, of course, there's higher danger that you're imposing on others, and also the higher expenditure that treatment of the potential diseases developed due to smoking is posing on the society as well. Now, when we're thinking of taxes as a corrective mechanism in a market that has negative externalities, we're trying to align the private cost with the social cost, right? But when we're thinking in a market that is looking at cigarettes, the kind of classic issue is that if this is the marginal benefit of smoking, this is the marginal social cost, but the private cost is lower, right? This is the marginal private cost. So the private market would be delivering this quantity, whereas the socially optimal is this one, right? This is what we should be producing as a society. But the failure to kind of recognize this external cost is what leads to this market failure. But when we're thinking about a market for cigarettes, what we know is that the demand is going to be extremely inelastic because it is an addictive good, right? So if we have a supply and we're taxing here, if we're using a tax wedge, even a very large tax is going to have a relatively small impact on the quantity demanded. The elasticity of demand is estimated to be only about 0.4, negative 0.4, so very inelastic. So when we do impose the tax, part of the impact that we're trying to get is to get people to quit smoking, perhaps. So that would be the extensive margin, right? That it would be fewer people smoking, but that's very limited. So we see about half in the sort of prevalence and half in the number of cigarettes smoked. So on the intensive margin, there's going to be fewer. Even though the number of smokers is not changing, but they're going to be smoking slightly fewer cigarettes. So instead of lighting one from the other, they're going to take a little break in between. So extensive margin impact means there would be fewer smokers. That's going to be somewhat limited here, but also in the same space, we might not reduce the number of smokers, but we might reduce the number of cigarettes each smoker is actually consuming, and that is the change on the intensive margin. So why are we thinking of involving the government here, right? Why even get them in this space? So we argue that young people are poorly informed, and that their demand is much more elastic. We also think about the young consumers as someone who is underestimating the health consequences and the addictiveness of cigarettes, because they can think that even if they start, they can really quit at any time, right? So part of it is that the young consumers are really poorly informed. And we believe that they have a more elastic demand than the older ones, right? For them, it's a much bigger chunk of their budget, so they're going to be more sensitive to the price. The other reason why, the government is getting involved is also because government pays for a substantial portion of the spending, right? So about 50% of the healthcare costs associated with smoking are paid by government programs. So the government has sort of a beef in this. And even though the revenue might not be, right, necessarily the imposition of the tax might not have that big of an impact on the reduction in smoking, there's going to be a very large revenue that's going to be generated from imposing the taxes. And that revenue is then used for cessation therapies, for example, so to help people who would like to quit smoking to get some assistance. The other piece, so government pays for a substantial portion of spending. And the last piece is that people, when it comes to smoking, have inconsistent preferences, inconsistent time preferences. We call this hyperbolic discounting. We talked about discount rates in the past, that people who are future forward-looking have a low discount rate for the future. People who are present-oriented have a high discount rate for the future. For smokers, if you ask them when they want to quit, it's always tomorrow. But if you ask them tomorrow, it's also going to be tomorrow, right? Hence the inconsistent time preferences. So most smokers, if you ask them, they do want to quit, but they're simply not quite equipped and don't have the willpower or whatever, given the addictiveness, to actually do so. Okay, so that's one vice. Now let's switch to alcohol. So if we're thinking about alcohol, there is some evidence that moderate consumption can actually be beneficial. I wrote my second year paper in grad school on the benefits of drinking wine on heart disease. So it is, there's some evidence that it is actually beneficial. It is possibly increasing your good cholesterol, decreasing blood sugar, wine, has been linked to somewhat of an increase in life expectancy, protects against lymphoma, but that is, of course, if it's moderate, right? Excessive drinking is much more dangerous, and in the short run, the negative impacts, of course, are, you can go into coma, you can die, so deaths. So these are kind of one-time excessive, right? Binge drinking. We can think of car accidents. Again, this is a huge potential externality, right? And violence that's linked to overconsumption. If you're thinking long-run effects, that is, right, damage to your liver, brain cells, loss of brain cells, ulcers, lower productivity. Some evidence suggesting also lower educational attainment. If it's during pregnancy, that results in fatal alcohol syndrome and permanent damage to the baby. And there has been some evidence linking alcohol overconsumption to some forms of cancer as well. So, I was in grad school in 2008. In 2009, the American Heart Association basically said that risks outweighed the benefits, and they do not recommend drinking at all, I guess. Now, if we're thinking about spending, it's about somewhere between half and 1% of household expenditures. So that's, again, a decent chunk of our money. We used to have a ban on advertising till 1996 for spirits, but now advertising amounts to about $3 billion in ads annually. So very much a thriving industry. Now, consequences of drinking, it's one of the leading causes of deaths. So 60% attributable to disease. So leading cause of death. So again, about 60% of this is by disease. So that's your cirrhosis of the liver, strokes, and so forth. And about 40% of this is due to alcohol abuse. So here we would be talking about the accidents, violence, and so forth. So in terms of public policy, just like with smoking, we have some externalities here. So certainly public response, so public policy, is to tax alcohol. We have minimum age in most places that reduces high school consumption. It's also making it kind of I don't know, the drinking age at 21 and being able to vote at 18. I'm still trying to wrap my head around this, but it's also part of this is that clearly younger drivers are less responsible, invincible. They think nothing's going to happen. We also have a problem in the US of lack of public transportation. So in Europe, for example, kids don't have to drive to get to school or anywhere. So even if you're 18 and you have a beer, nobody cares. But here, because we don't have a kind of a developed public transportation system, you have to drive everywhere. So getting kids behind the wheel and allow them to drink is an issue as well, right? So it's sort of kind of interrelated here. So we have definitely drinking and driving policies, so limits, drinking, so limits on blood alcohol level in most states. We have, again, I don't really understand that, but we have time limits on when you can buy alcohol. So if you go to the grocery store on Sunday morning here, you can't buy booze. Apparently it's not okay to drink on Sunday morning. Not sure how big of an impact that really has, because if you really want to drink, then you're going to buy it Saturday night. We have campus restrictions on drinking. So there's certainly lots and lots of public policies that are directed to aiming at decreasing alcohol consumption, given the negative outcomes that can be associated, especially among the younger population, who may be engaging in the kind of one-time excessive consumption and binge drinking. Okay, so we covered smoking and alcohol. Those are the legal vices, I guess. So next one up is illicit drugs. I guess this has also changed a bit, as now some states are actually allowing or decriminalize, not just decriminalizing, but also legalizing marijuana, for example. But when we think of illicit drugs, certainly some of the most, direct costs are damages to tissues and organs. If you've ever seen pictures of meth addicts without teeth and so forth, right? So there's direct kind of health consequences. So the damage sort of varies by the type of the drugs. So if we think of stimulants, so those are your cocaine and similar things. Those are going to increase your heart rate, which is constricting blood vessels, and that leads to higher rates of cardiac arrhythmias and stroke. So cardiac arrhythmia and strokes. Then if you think of MDMAs and things like ecstasy and so forth, those are more linked to things like kidney damage and, of course, death in case of an overdose. The same for heroin consumption as well, right? So those are sort of the kind of direct health issues. But a big thing that we can't forget is also kind of social outcomes, right? So inadequate housing because of the choices and lack of resources, right? Poor nutrition among addicts, much higher exposure to other diseases, So higher exposure to disease and infection. Violence and crime is just like for kind of alcohol and crime, certainly here even more so. So speaking of infections, for example, and higher exposure, so there's a recent paper that was published in the Journal of Public Economics that looks at syringe exchange programs. And lots of with the opioid crisis, many public health entities have called for an expansion of these exchange programs, which provide access to sterile syringes and facilitate safe needle disposal for injection drug users. This paper uses a newly constructed administrative data set to estimate the effect of recent syringe exchange programs openings on HIV diagnosis and drug-related death. She finds that the SEP openings decrease HIV rates by 18.2%. However, I present new evidence that these SEP centers increase rates of opioid-related mortality. Effects are largest in rural countries and in counties that adopt SEP after the influx of fentanyl in the U.S., suggesting that needle exchanges may be less effective during periods when illicit opioids are widely available, especially in areas with high barriers to substance abuse treatment. So in the paper, they really talk about sort of how this impacts the public policy, right? So they state that these findings shed new light on the effectiveness of the syringe exchange programs alone in combating the ongoing opioid crisis and present the trade-offs inherent in such public health interventions. But this new evidence is also crucial as state and local governments search for ways to reduce rising rates of opioid dependence. Indeed, some recent studies have shown that state-level restrictions, including prescription limits, patient ID laws, prescription drug monitoring programs, doctor shopping restrictions, pain clinic regulations, and naloxone laws have been shown to be ineffective at curbing opioid use. However, other studies have shown that provider-level interventions can be an effective avenue to address rising rates of opioid use in the U.S. For example, some recent work has documented that prescription drug monitoring programs can decrease the number of oxycodone shipments, opioid abuse among young adults, and misuse for Medicare Part D patients, but are most effective when doctors are required to consult them. Moreover, physician training can reduce opioid prescribing, suggesting that certain supply-side policy may be an effective way to address opioid misuse. So there's still some evidence that there's a large role of doctors in this as well. Okay, so when we think of marijuana, for example. So as I said, that is now in many states, changes in law and legalization is very prevalent. The discussion has always been, is it a substitute versus is it a complement? Is it a gateway drug, right? So there's been some evidence that they're more of a complement than substitute with both cigarettes. So marijuana and cigarettes being complementary, but also with marijuana and cocaine, for example. So not necessarily a substitute. So lots of kind of changes there. When you think about the impact of it and not being linked as a gateway drug, then legalizing it the same way that, alcohol consumption is somewhat regulated, you might as well take advantage of taxing this and the government's actually being able to collect the revenues for publicly funded program instead of this being an illicit, off the books sort of black market transactions. So when we think of addiction in general, there's a few things that make it kind of tricky to model in economics. So we talk about the issues of reinforcement. So that is literally the learned response from past consumption, which increases your marginal utility of current consumption. So when you've had this before, right, this new consumption has a higher marginal utility because you've experienced this before. So this is that reinforcement effect. The other issue is tolerance that goes sort of in the opposite direction. So given level of current consumption, is less satisfying here. So that gives you lower utility when past consumption is higher. And the last one here is withdrawal. So that's the negative physical reaction. And a reduction in utility. As current consumption is terminated. So when we think of addiction and try to model the behavior of people who are addicted, right, these are sort of the three things that we have to take into account. There is some reinforcement, so you learn how to, how it feels, you get kind of a better high, I guess. But also you're building up tolerance. So the current consumption is less satisfying because you're building up this tolerance. And there's a very negative utility reducing response if you cease consuming, right? So there are still models that can sort of model addiction in a rational way. So models of rational addiction. So we think of here utility is a function of past consumption. Current consumption depends on your past, future, but also current factors. So you want to think, like price and stuff as well. So when you're modeling this decision, it's, you can sort of take these changes in utility into effect and see how that works. Now, at the end of class on Monday, I kind of got you thinking about this with the short video of Ann Case, where they're kind of attributing the rise in these overdoses and deaths of despair to the lack of opportunities and also issues of mental health, which is really kind of coming to issues of higher importance. We looked at the paper by Chris Cronin of the kind of recognizing this as well, but certainly the rate of deaths have spiked in the U.S. and has been of concern. We've looked at this figure before when we talked about pharma and the overuse and stuff, how really the fentanyl and synthetic opioids have gone up. We talked about the implications of the reformulation and really kind of how heroin then has taken off again as well as sort of a substitute, right? So this has been a big issue. Now, the one piece of kind of interesting news in this space also is, so this shows the disparities. They call it saved by the bell, because there's a big sort of educational component, right? So while the educational gaps in mortality has widened, the racial gaps have actually narrowed, right? So if you look at blacks without any degree, this is life expectancy at age 25. With a degree, it's much higher. So we're getting the high education is getting closer, but whites with no degree have literally made no progress whatsoever, and the blacks are sort of catching up even with no degree. So part of this is clearly the education piece being better producers, but the Angus and Deaton paper is talking specifically about this, right? That we have made no progress because there is actually this contributing factor of these deaths of despair that are causing higher mortality among less educated, particularly white men. I'm also going to post on Canvas this short, it's just 4 pages, not really 2.5, 3.5, from the New England Journal of Medicine that recently came out just in October, I think so, fairly quickly, that's taking a look at the issues of health equity and kind of comparing the different policies present and past of the two candidates. And I guess a few things that they highlight are the following graphs. So these are looking, panel C is about obesity that we talked about today. Panel D is on the maternal mortality we discussed earlier. A and B are what we talked about today. So overdoses, and then, violence and firearms also very much related to sort of alcohol consumption and other things as well. So I thought you guys would enjoy reading that one. It's pretty well put together. Okay, we'll at least start the intro to health insurance as well. Okay, so some of the big issues with health insurance and sort of the traditional coverage in the US is that historically it has been a very much employer related private health insurance coverage. That is the dominant one. So, employer paying for your coverage, not necessarily. So, the Ann Case video I showed you kind of talked about that it's a compensation from the employer that. They're providing you with some pay, and to them, honestly, it doesn't really matter whether they pay you wages or they provide you with health insurance, right? So it's more kind of like sponsoring it in a sense, because if to them it really does not matter. To you, it's going to have some tax implications that we'll talk about as well. But historically, this sort of tying insurance coverage to employment led to what we called a job lock, that people couldn't or wouldn't leave their jobs to seek perhaps a better match, a more efficient match of you being productive, because if you had a pre-existing condition, switching a job would mean that you go to a new insurance company and they could deny coverage, right? So that's been eliminated with the Affordable Care Act. That can no longer be held against you. So you can get a new coverage with the company. They have to insure you, and you also have options to get coverage outside of just employer-sponsored health insurance. So when we think about kind of employers paying you, the typical way to look at wage is really thinking of the worker's kind of marginal revenue product. So the MRP, right? So it's a compensation of a worker in a competitive market. And what this really is their marginal productivity. So how much more of an output are you able to produce? But it is times the price of the product that you are helping to produce. So the value basically of you to the company is reflected in how productive you are in terms of your own effectiveness at producing the good, but also the higher the market value of what you're selling is also going to increase the value of you to the company. So when you think of compensation and sort of the trade-off here between premiums and paying for insurance versus your wages, for the company, it really kind of is like, okay, if I have a certain worker with a given MRP, more expensive health insurance, then means I'm going to give them lower wages or compensation, right? So maybe you get lower fringe benefits or something, but it's still money on the table relative to the value that you bring to the company. If we look at the empirical studies, we definitely see that more productive workers tend to receive higher wages and also higher insurance coverage. And better kind of health insurance coverage being provided is certainly associated with fewer wages that we see, and about 10 to 11%, which is about $2,000 at the time of that study, which was about equivalent to the cost of health insurance. So we've shown that firms are still paying you the same amount, but instead of paying that to you in wages, they're now giving you the insurance benefits. So does health insurance actually make a difference? Right? We've looked at a few studies, and some of them are on your readings. The 2019 Zach Golden paper shows that higher insurance is decreasing mortality, and this was an experimental evidence, so it is causal. Right, it was the taxpayer outreach where they were kind of promoting this. So we certainly want people to have health insurance because it is linked causally to better health outcomes, and here are the ultimate one, so decrease in mortality. So when we think about kind of a demand for health insurance, I want to kind of highlight one important aspect here. When you think of demand for health insurance, people don't necessarily want to buy health insurance, what they're trying to get is someone to pay for their healthcare expenses, right? So so this is by definition has to be a function of some sort of uncertainty and risk, because people are trying to purchase health insurance to avoid or transfer the risk. If you think of so let's say you guys were riding bicycles on campus, and on average, one bicycle gets stolen, misplaced somewhere a semester. So if there's 50 of you in a class, let's say you have a $100 bicycle, you are facing this risk, this probability, 1 out of 50 of you will have their bike stolen this semester, and you will need to come up with $100 to replace the bicycle. So if you don't have insurance, you have to live with this risk that you might have this big expense of having to pay $100 if your bike gets stolen. So if we wanted to insure ourselves as a class, we would need enough to pay for one bicycle being replaced. So we'd need $100. So that means there's 50 of you. Each of you could put $2 in a pool. I can hold on to it. I'll have $100. And when one of your bikes gets stolen, then that person gets a new bike. And all it cost you was a $2 in the premium, right? So that's a pretty good deal. So that is you willing to pay $2 and lose $2 of your money to avoid the risk, even though it might be small, 1 out of 50, that you will have this big shock and expense of $100. But what happens if now the theft risk goes up, and let's say 10 of you might get a bike stolen? Now I might need $1,000. So with 50 of you, that would mean that we need each of you to put in $20 to cover the 10 bikes being stolen, right? If now we would get to a point that the risk is no longer a risk and it's not uncertain, but we know that every bike would get stolen, so this is equivalent to somebody having a chronic condition, then my expected losses would be 50 times 100. I would know that that's how much money I'll need to replace everybody's bike. So how much does everybody have to pay in? Everybody would have to pay in $100. That would be your premium, but that's exactly what the expected loss is going to be. So if there is no risk, if there's no uncertainty, the effective kind of pitch-in amount for the premium is actually equivalent to the cost of treatment. And this is why there is no sense in people getting insurance for conditions that are certain, like pre-existing conditions, because there is no longer any uncertainty. The risk is 100%. That's why you, for example, don't really see insurance for eyeglasses. It's more like these discount plans, because who would sign up for insurance for eyeglasses? Just people who need glasses. So again, that would be no uncertainty. That would be 100% likely that you're going to go and get a pair of glasses. The same with dental insurance. These are more certain outcomes, so there's a very limited role for insurance. So this is really about uncertainty and reducing this uncertainty. So when we model the demand for health insurance, we're going to use this sort of conventional theory that we call the standard gamble. So this is assuming that people purchase health insurance to avoid or transfer this risk, right? So the insurance is going to serve as a pooling arrangement, and this reduced risk is associated with the aggregated losses here. So in this framework, right, we're going to assume that there's imperfect information. In the healthcare sector. So you don't know when you'll get sick or when you'll get hurt. So this uncertainty leads to risk. And most people are willing to pay to avoid risk. Right? That's kind of the whole point about insurance. That's what I just described. Like, we'd all be willing to put $2 in a pool to make sure that we don't have to come up with $100 when our bike gets stolen, right? You're willing to say goodbye for sure to $2 to avoid the risk of 1 out of 50 chance having to pay $100. So imperfect information. Then we're also going to assume that there's going to be some pooling arrangements, so putting people together. That was kind of the feature of the bicycle program as well, right? When we put 50 of us together, then I only needed everybody to pitch in $2. So pooling arrangements, so that's a feature of health insurance policies, and this helps mitigate some of the risk. And then also what people are worried about, so people's concerns, are really about the total expected loss, how much you think you're going to have to pay, and also the variability of that loss. Now, what do I mean by the variability of the loss? So the variability is something that really matters to us. So if, for example, I tell you, you go to buy coffee at Starbucks and there's 2 baristas at the cash register, and you can either have people line up in 2 lines, or you can have 1 line that's splitting into the 2 whoever's free baristas. On average, the expected wait time is going to be about the same. But with the 2 lines, the variance of it is actually going to be much higher, because if you end up being stuck behind the idiot who has a long order and can't figure out where to pay and where his money is and whatnot, you might be stuck there and watch the other line just go and go and go and people getting their drinks. If you had 1 line, even though the average wait time would be about the same, with the 1 line, if you get stuck behind the complicated order guy, you would be able to just jump into the next line, and everybody would keep flowing through there, right? So the kind of risk of having a really short or really long wait time is much longer, much smaller. Okay, so let's think about these separately. So I'm first going to think about the expected loss. So expected loss, or expected value, I guess, of loss. That's what we really mean, right? It's going to be the sum of the weighted values. So given the risks and the probabilities associated with these outcomes. So I'm going to use mu for the expected loss, and it's going to be the sum. So the Greek, everything that's inside has to get added up together. The probability of outcome I, so pi is going to be for the probability, and L is going to be the value of the loss associated with it. So Li is the value of the ith outcome. This is the probability, so P of the ith outcome. So these are kind of the weights, right? And some of the weighted values of the outcomes is what I'm looking for as this measure of the expected loss. So for example, if I have a 30% probability of getting the flu, okay, and I have to see a doctor, which would cost me, let's say $300. I also have a 20% probability of just getting a cold and need some over-the-counter medicines. That would cost me $20. And the remaining probability, so 50%, is that I'm going to just stay healthy, which costs me nothing, right? So if I'm looking at the expected loss of this, I'm going to sum all of these outcomes. So it would be pi, okay, the probability of outcome 1 times the loss of 1 plus the probability of the second outcome plus the probability of the third outcome times the value of the third, right? So for this, I'm going to be looking at, so 30% times 300 plus 20% times $20, and then 50% times 0. So the expected loss associated with me, 30% chance of flu, 20% having a cold, and 50% staying healthy, I can expect to lose $94 on average. So this is my expected loss given these probabilities, right? 30% of the time I'll have to pay $300, 20% of the time just $20, half of the time nothing, but on average this means that it's an expense and an expected loss of $94. So that's the expected loss. But now we want to think about the variability of the expected loss. So this is really what we mean by the variance here, right? So this is the variance of the outcome. So if I'm thinking about the variance, that's going to be the sum, so also adding it up, of the, again, weighted by the probability of the losses of each outcome relative to the mean, relative to the expected loss, and we're going to square them so that we're dealing with, if it's a negative versus positive, they're not going to net out, right? So if we square them, they're all going to be positive numbers. So here the variance, it would be the sum of these. So it's going to be 0.3, that's the probability here, right? Times, and now it's the value of the loss for the first outcome, so that's 300, minus my average, so that's the 94, that's the expected loss, and I'm going to square this. Then I'm going to add 0.2 times, and now it's $20 minus the 94 squared. But this is what I was talking about, right? This number is going to be positive, but this one would be negative because 20 minus 94 is negative 66. So I would have a positive, and this would make that number smaller. Now that we square them, they're all going to be highlighting how far away we are from the average loss. And then 50% of the time, it's going to be 0 minus 94, and again squared, right? So if I add all of these together, the variance of this should add up to 18,244. Increases, the variance is going to get bigger when the probability of extreme outcomes gets bigger. So the more likely I'm going to be really sick, the variance is going to be bigger, right? The more likely you have either 0 or this whole big thing, the kind of noise and this variance in this in these outcomes are going to be bigger. Now, usually we talk about a standard deviation. And the standard deviation is basically the square root of the variance. So if I'm looking at the square root of the 18 to 24, so this would be 18,244, and that would be equal to 135.07. So the variance and the standard deviation basically serve as my measure of risk. So the more likely it is to have these extreme outcomes and the big expenses, the bigger the variance is going to be, because the more away I'm going to be from the mean. So now if I'm thinking about sort of the individual and their individual loss function, it's going to be associated with the medical expenses, but it's going to be heavily skewed to the right. So what I mean here is, if I'm looking at, right, these are the services, these are the costs, I'm going to have very few that are really expensive, and there's going to be a lot of them that are kind of lower expense. So this also will mean that the mean is going to be bigger than the median, right? That's what we mean by being skewed to the right. So only a few people will actually incur large medical expenses in the absence of insurance, and smaller losses occur more frequently than the larger losses. If you look at the evidence in the literature, there's a paper from about 20 years ago that shows that only about 5% of all patients accounted for more than 50% of the healthcare spending. I think we touched on it early when we talked about the costs in the Dartmouth Atlas that also talked about, right, the high share of the spending only by a small share of the population. So how does this variability, right, that we defined here, the variance and how kind of risky it is, how much am I risking when these possible outcomes happen, we want to talk about how does this change with pooling, right? So we talked about one feature of insurance being this pooling of risk. So let's actually think about how this is going to get set up. So if I think of pooling, I'm going to add another person. So let's say, I don't know, we'll talk about Anna. So Anna has a 20% probability of getting a flu, 10% probability of getting a cold. So she is going to stay healthy 70% of the time. So if I wanted to calculate her expected loss, so her expected loss would be 0.2 times 300 plus 0.1 times 20 plus 0.7 times 0. So her expected loss would be $62. That makes sense. It's less than mine, right? Because she's less likely to have a flu and less likely to get a cold. So while I'm expecting, to on average lose $94, she's only expecting to lose $62, right? She has lower probability of these expenses happening, so her expected loss is smaller. I'm also going to calculate her variance and standard deviation. So for the variance for Anna, again, I'm taking the same approach here, right? Summing up the probability, the weighted deviations from the mean. So each outcome, how far is it away from the average outcome? So here, if I add these up, so it would be again 20% times 300 minus 62, 10% times 20 minus 62, and 0.70 minus 62, and I should get, I think, 14,196, which is less than what my variance was. Her probability of these extreme outcomes is smaller. So her variance, her risk is smaller. And the standard deviation for this would be 119.15. So her measure of risk is smaller than mine. Okay, so now how does the pooling come into play? So this is what I want to talk about. So we have two consumers, me with an expected loss of $94, Anna with an expected loss of 62. My measure of risk, variance, standard deviation, is bigger than hers. This is how risky it is for us to have these big expenses. So now I'm going to put us together, okay? So I'm going to set up a table here. We'll need 5 columns. So I'm going to need basically the outcome column. Then we're going to need the combined probability. We're going to need the combined loss. And we're going to have the probable loss. And that one person's share. So I need 5 columns here. Okay. Now, what are the possible outcomes here? So the possible outcomes here that both me and Anna, so Eva and Anna, are going to stay healthy. So we have a 0 expense. Okay. What does that mean? What is the probability? So for me, the probability of being healthy is 0.5. Now, from stats, if you want to get the probability of me and Anna staying healthy at the same time, we actually multiply these. So it's going to be 0.5 times 0.7. So the probability that we both stay healthy at the same time is actually 0.35. So in combined probabilities, it means that you multiply, right? Okay. So how much would we be losing? 0, because that's actually no expense, right? So probable loss is also 0, because probable loss here is, so let's name this column 1 and this is column 2. This is 1 times 2. And then this would be 2 divided by 2 because there's 2 of us, right? So still each person's share is 0. Okay, that's the first outcome. Then let's say I have no expenses. I stayed healthy, but Anna has the flu. So I'm healthy. Actually, let's just spell all of these out. So I can stay healthy. Anna has the flu. Here in the first one, I'm healthy and she's also healthy. I can also be healthy and Anna can have the cold, right? So those are the 3 options where I'm healthy. Then I can say, okay, now Anna stays healthy and I'm going to have the flu. Then Anna stays healthy and I'm going to have the cold. So that's all the combinations of either me being always healthy or her being always healthy. And then I can say, okay, now Anna can have the cold and I can also have the cold. I can have Anna having the cold and me having the flu. That's another outcome. I can have Anna having the flu and me having a cold. That's the next one. What am I missing? We can both have a flu. And I think that's it. And then we'll need a final column just to summarize all of them. Okay, so now that we have all of these possible outcomes, so me staying healthy and Anna having the flu in here. So I'm staying healthy half the time. She has the flu 20% of the time. So this is a combined probability of 0.1. Me staying healthy is 50%. Her having the cold is 10%. So this is the probability of 0.5. Her staying healthy is 70% times me having the flu, which is 30%. So this is 0.21. Her staying healthy, 0.7. Me having the cold, that's 20% of the time. So this is 0.14. Her having the cold is 10% of the time. Me having the cold is 20% of the time. So this is 0.02. Her having the cold is 0.1. Me having the flu is 0.3. So this is 0.03. Her having the flu is 20% of the time times me having the cold is 20% of the time. So this is 0.04. Her having the flu, 0.2 times me having the flu is 0.3, 0.06. If I add these up, they'd better add up to 1, right? So this is going to be the sum of 1. Okay, so now the combined losses. So this is a loss of me staying healthy, right? So here I am staying healthy. Anna has the flu. So we're going to lose $300, right? Here, I am healthy. She has a cold. That's $20. Anna's healthy. I have the flu. That's $300. Anna's healthy. I have the cold. That's 20 together. We both have a cold. Now that would be $40, 20 each. Anna has a cold. I have the flu. So that's $320. She has the flu, I have the cold, that's also $320. If we both have a flu, that's $600, okay? Now the probable loss here is these columns multiplied. So there's a 35 chance of having both of us healthy times this. Now there's a 10% chance that she's going to have a flu and I'm going to stay healthy, and that would be a $300 expense. So 0.1 times 300 is the probable loss here, and that would be $30. 0.05 times 20 here will be $1. 5% out of 20 is $1. 0.21 times 300, this is 63. I'm just going to fill these in. 2.8, 0.8, 9.6, 12.8. This is 36. Now, if I sum these together, this is going to be $156, which is exactly the same as the 94 plus the 62. Those were our expected losses, right? That's what we calculated before, so it's the same. But now, if I'm going to cut all of these in half, that's each person's share, right? Because we're splitting it in half. 0.4, 4.8, 6.4, 18. Now each person's share here is 78. So now this is the expected loss for me and for Anna. We both have the same because we added it up together, the 156, and now we're splitting it in half. We're pooling the risk together. So how does this work then if I want to compute the variance? So the variance here will be, I'm going from this table, is going to be the 0.35, that's the probability of the first outcome. The expected loss here is 0 minus the 78, which is the one person's share, right, and squared. Then I'm going to be 0.1 times, now this is $15, right? How much is the person's share? 15 minus 78 squared plus 0.05. This would be 0.5 minus 78 squared. And I would go, right, this times this times this minus the expected value. So the same way, I'm not going to do it for all of them, but I would come up with a number that's 4,804.39. Now, my variance before was 18,000, hers was 14,000. Now our variance is 4,800. The standard deviation, the square root of the 4,804.39, is only $69.3 on average. So our risk of having this high expense away is much, much lower for us. We have much lower risk of high expenditures. When we pool this together, our expected loss really is just 78, and the variance, the risk of having a really, really high expenditure outcome is much smaller. And this is the big benefit of pooling the risk. So the standard deviation or the loss of the loss distribution declines and further decreases as more people join, right? It doesn't reduce the expected loss. This is still the same. This never changed. But what does decrease is the risk of these big expenses. When we pool it together, right? When we pooled the bike insurance, the more of us were together, on average, the loss was much, much smaller. So pooling people together is huge. So consumers gain because of this reduced variability and the reduced risks, because each person's individual loss distribution is now replaced with the average loss distribution. So this pooling is really, really important. Okay, I'm going to stop now because I'm sure I went way faster than I would go with you guys being in person. So I'm going to cut it now, and then we'll take off from here when we get back to class on Wednesday. Sorry.